Hello everyone. So now we'll be talking about the diagnosis and the treatment for Parkinsonism disease. So for the diagnosis, it's basically a clinical diagnosis. There is nothing as investigation for Parkinsonism disease. And for the treatment, you need to know the name of the drug, uses, adverse effect. For this, I'll be taking help of KT Tripathi. So for the drug, you need to remember that there is this levodopa. This levodopa, it crosses the blood-brain barrier. It goes over here. Now this levodopa can actually convert it to dopamine by the help of dopa decarboxylase. Okay, by this DDC is dopa decarboxylase, and this COMT will actually convert into 3-OMT. You don't need to remember all this. Just remember this COMT. It converts into certain degraded product. Okay. Now this COMT inhibitor is actually entacapone and tolcapone. Okay. Now you need to remember that inside the blood-brain barrier, it goes like levodopa is there, and this levodopa will actually convert it into dopamine by the help of dopa decarboxylase. But peripheral dopa decarboxylase inhibitor is needed as a treatment, like carbidopa and benseradide. Centrally, it's not inhibited. Okay, like in the brain, it's not inhibited. Okay. Now COMT inhibitor is tolcapone. Okay. Now this dopamine precursor, we can sometimes give dopamine precursor itself, and dopamine agonist precursors are actually drugs like bromocriptine and ropinirole. Okay, bromocriptine, please write it down. Bromocriptine and ropinirole. Okay, bromocriptine and ropinirole. Okay, you need to remember this. Okay, now the most important thing is the okay. So you need to remember that there is dopamine precursor, which is known as levodopa. Peripheral decarboxylase inhibitor is carbidopa and benseradide. Dopaminergic agonist is actually bromocriptine, ropinirole, and MAO-B inhibitors is racesilin, selezilin. COMT inhibitors is entacapone, tolcapone. Okay. Now, levodopa. So whenever we talk about levodopa, what we need to understand is whenever we talk about levodopa is the group of drug which is very, very, very important. Okay. So levodopa is a very, very important group of drug. Now levodopa, you need to understand that levodopa in the CNS, it tends to improve the hypokinesia, hypomimia, facial expressions, okay, rigidity, resting tremors is all improved in the case of CNS. Okay, in the case of CVS, what it causes is it leads to postural hypertension. Okay, postural hypertension. Now this postural hypertension can lead to reflex tachycardia. Okay, reflex tachycardia. In the CTZ, what it leads to? It leads to nausea and vomiting. Okay, it stimulates the CTZ and that leads to nausea. So see here. So patients, hypokinesia and rigidity resolve first, tremors as well. Second symptoms of posture, handwriting, speech, facial expression, mood, self-care, and interest in life are gradually normalized, right? And CVS, the peripheral form dopamine can cause tachycardia. Okay, by acting on the beta adrenergic receptors. Okay, beta adrenergic, basically the B1, and it leads to postural hypertension. Okay, and CTZ, it leads to nausea, vomiting, right? And when we talk about the endocrinal function, we know that dopamine will actually inhibit the level of prolactin. So it will inhibit the prolactin release. Okay. Now, whenever we talk about the management of this one, management of Parkinsonism. So nausea, vomiting, postural hypertension, cardiac arrhythmias, exacerbations of angina, and alteration of taste sensation is really seen with the dopamine. Okay. Now, what other things that we need to remember is we need to remember that after prolonged therapy, you will have an on and off effect. Okay, so there is something which is known as an on and off effect, which is seen with dopamine. Okay, so how are you going to treat that on and off effect? See, I would like to read all this. Okay, because this is very, very important. After 2 to 5 years of therapy, the level of control of Parkinsonism symptomatology starts showing fluctuation, end of dose deterioration, weaning off, which is initially gradual, develops into rapid switches or on and off effect. With time, all or non-response. So what is all and non-response? That means either it will actually show the response or it will not show any kind of response. That is known as all and non-response. Okay, it is known as all and non-response. Okay, now other things that we need to remember and take under consideration is other things that we need to take under consideration is uh, so abnormal movements may jeopardize even on the on phenomena. This is probably a reflection of progression of the disorder with progressive degeneration of the dopaminergic neurons. The ability to regulate storage and release of dopamine is largely lost. Okay, and that is why there is fluctuation in the activity. That is what you need to understand. Okay, uh, dopaminergic agonists like bromocriptine, rapidinol, and ropinol can be given. MAO-B inhibitors, you need to remember resigilin, saligilin. And what's the adverse effect of MAO-B inhibitor? So let's first of all talk about COMT and then we'll come to MAO-B. So MAO-B inhibitors, it's used with levodopa. Used when levodopa. So the adverse effect is postural hypertension, nausea, confusion, attenuation of the levodopa induced involuntary movement. Okay. See, saligilin, S for saligilin, S for insomnia. Somnia, sleep disorder, disturbance. So, saligilin can lead to sleep disturbance, okay? Right. Now, other things that you need to remember is entacapone and tolcapone can lead to, what can it lead to? Entacapone and tolcapone can lead to the same, okay, worsening of levodopa, like adversity, like nausea, vomiting, dyskinesia, postural hypertension, hallucination. However, this can be minimized by aggravation of the levodopa dose, okay, minimizing the dose, and sometimes entacapone can lead to discoloration of the urine, okay, yellow-orange discoloration of the urine. Is also seen with rifampicin, okay. So this completes our treatment with Parkinsonism. Newly advanced treatment for Parkinsonism is actually we can give deep nerve stimulation. Okay, so brain stimulation can actually be given. That's a newer modality of treatment for Parkinsonism. Okay, so that on and off effect is also known as the honeymoon effect. Okay, it's also known as honeymoon effect. Okay, and the newer modality of treatment is the deep brain stimulation. Okay, deep brain stimulation. This completes our Parkinsonism. Thank you.